This meeting is being recorded.
Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar exploring the SUPTRS Block Grant Report. Before we begin, I'd like to review some housekeeping items. Due to the number of participants on this call, all participant lines will be muted for the duration of this webinar. If you have any comments or questions, please submit them at any time by using the Q&A window. To open your Q&A window, please click on the Q&A icon that's located in the bottom center of your Zoom window. Questions are encouraged to be submitted throughout the presentation. Closed captioning is also available. To turn on closed captioning, click the CC icon that's located on the bottom of your screen. If you experience any technical issues during this webinar, please message us using the chat feature, which is also located at the bottom center of your screen, or simply email us at samsastateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and accompanying PowerPoint slides will be made available and shared with participants at a later date. Next slide, please. Today's webinar will begin with a welcome from SAMHSA's Spencer Clark and Torrance Brown. Spencer Clark serves as branch chief of the State Systems Partnership branch within the Center for Substance Abuse Treatment. He considers himself to be very privileged to lead a staff of 9 CSAT state project officers who provide planning, monitoring, and oversight of the SUPTRS Block Grant in partnership with a total of 60 grantees representing the 50 states, the District of Columbia, 5 U.S. territories, 3 freely associated states, and the Red Lake Band of Chippewa Indians. Prior to his employment at CSAT, Spencer served for 28 years in the North Carolina Single State Agency for Substance Abuse Services, including serving as Chief of Addictions and Management Operations and Administrator of the North Carolina State Opioid Treatment Authority. Spencer is a licensed master social worker in the states of Maryland and New York. Torrance Brown is the director of the Division of Primary Prevention at SAMHSA's Center for Substance Abuse Prevention, leading a national prevention grant portfolio, including the SUPTRS Prevention Set-Aside, PFS States, PFS Communities, STOP Act, and congressionally directed spending grant programs spanning all 50 states and select territories. With over 20 years of progressive federal public health leadership across HHS, including HRSA and SAMHSA, he's guided by a Reach One philosophy, positively impacting at least one person, place, or thing, driving lasting, multiplying change. His work centers on advancing community investments and prevention systems nationwide. Spencer, I'll now turn to you.
Thank you, Matt. I must say, first of all, I'm not only privileged to work with our fine staff at CSAT, but also with all of our grantees. It's quite a privilege to work with you each day. We are very appreciative of JBS as a partner who helps us with this webinar, but with all of our state TA products. And so hats off to them. This presentation has been a bit in time coming. We've had some really good work on this by Savvy and Kabai and others, and we're really looking forward to doing the presentation and also your question and answer afterwards. So we've got a little time here. As you know, the report is not due until December, so we've got a bit of lead time here for a change, and we're very happy to be able to put this presentation out for today. Thank you so much for this privilege. Torrance?
Thanks, Spencer. And good afternoon, everyone, and welcome to the Block Grant Report webinar. As Matthew mentioned, I'm Torrance Brown, and I bring you greetings on behalf of Rear Admiral Chris Jones and the entire Center for Substance Use Prevention. Today, you are in very capable hands with Savvy and Kabai as they walk you through annual updates, expenditure data, performance data, and outcomes as well. Please take good notes, ask good questions, and participate in the chat also. Please do share this information with your colleagues who were not able to attend. Thanks again for joining, and I would turn the microphone back over to Matt, Savvy, and Kabai.
Thank you, Spencer. Thank you, Torrance. Next slide, please. I will now introduce our presenters for today's webinar. Savannah Brennicke serves as a State Project Officer on the SUPTRS Block Grant in SAMHSA's Center for Substance Abuse Treatment. In her role, Savannah oversees 7 states under SUPTRS Block Grant and serves as SUPTRS Block Grant subject matter expert for block grant planning and reporting requirements, the WebBGAS system, and the treatment episode datasets. Prior to joining SAMHSA, Savannah earned her PhD from Johns Hopkins University, where she trained as a National Institute on Drug Abuse pre-doctoral fellow in drug dependencies epidemiology. She also managed the NABI Consultants, where she worked as a private consultant to nonprofits and state agencies in Indiana on public health program development, implementation, and evaluation. Her near decades-long career in public health has included testifying before the Indiana State Legislature and advocating on behalf of addiction science and policy on Capitol Hill. She holds a Master's of Public Health from Indiana University and a Bachelor of Science from Purdue University. Kabai Dariba serves as a public health advisor on the operations team within the Division of Primary Prevention in SAMHSA's Center for Substance Abuse Prevention. In this role, she provides oversight and technical assistance for 2 states under SUPTRS Block Grant and serves as CSAP's SME for the SUPTRS Block Grant. She brings more than a decade of experience in public health and behavioral health, including service delivery and community-based programming. Prior to joining SAMHSA, Kabai served as Director of Overdose Prevention at the National Association of County and City Health Officials, where she led initiatives to strengthen local public health capacity to prevent and respond to overdose. She earned a Bachelor of Arts in Health Administration and Public Policy from the University of Maryland, Baltimore County, and a Master of Public Health from the University of Sheffield in England. Savvy, Kabai, I'll now turn to you.
Thank you for the introduction, Matt, and the welcome from Spencer and Torrance. A quick note for everyone in the audience, all the reporting requirements we're going to discuss in today's presentation are going to be consistent with changes that went in effect in the 2026 report. So there are no new changes to the report that's due December 1st, 2026. This information that we're going to provide is more for emphasis and clarification around the reporting requirements for the SUPTRS Block Grant. To the right, we have a QR code that will link you to a PDF copy of all of the reporting tables required for the SUPTRS Block Grant annual report. So let's dive in. Let's start off today by covering the high-level requirements of the SUPTRS Block Grant annual report. There are 2 parts to the state's reporting requirements for SUPTRS Block Grant. There's the annual report covering treatment and primary prevention that is due December 1st every year. Then there's the annual SINI report due December 31st that is required to meet the primary prevention statutory oversight of the sale of tobacco products to individuals under the age of 21. Both reports must be submitted and approved by SAMHSA in order for the state's application to be considered complete. We'll be focusing today's presentation on the larger SUPTRS Block Grant report that's due December 1st. This report includes a combination of fiscal compliance and performance under the block grant. All reporting requirements we'll discuss are covered by statute and implemented through regulation. Links for your reference are provided here. The annual report is broken down into 5 parts, all of which are listed here. And today's presentation, we're really going to focus on covering sections B through E, and we'll walk through those sections in the order which they appear. Something for all state staff to be aware of when supporting the completion of the SUPTRS Block Grant report are the various fiscal and calendar years reflected on tables. The fiscal year for any given table is going to be found at the top of each table when in WebBGAS, and we're going to cover some of these really quickly. First, we have the state fiscal year, or SFY. Tables that are reported on the state fiscal year, expenditures or performance, must do so by using the most recently completed state fiscal year at the time of the report. For many of you, your state fiscal years will run from July 1 through June 30th, but regardless of when your state fiscal year starts and ends, the tables listed above should reflect expenditures and performance during that same 12-month period. All right, next we have a set of tables that require the state to report on federal fiscal year, which runs from October 1 through September 30th. These tables in the report will be for the SUPTRS Block Grant award that was made 3 years prior to the reporting year being completed. So in other words, this year's 2027 report will reflect state reporting on the tables above for the federal fiscal year 2024 block grant award that the state received. Much of today's presentation will focus on the interrelated nature of many of the block grant tables, with examples being provided. The relationships we'll focus on are those for the SSA expenditures and maintenance of effort, expenditures of the block grant award, and compliance with the statutory set-asides and caps, as well as populations served with block grant funds and the national outcome measures and performance. Now let me turn it over to Kabai, who's going to get us started as we dive into the finer details of annual reporting requirements.
Thank you, Savvy. Let's get started by reviewing the first table that appears in your report, Table 1.
Good news here is that the changes related to this table are minimal. The primary update is the addition of a new population category, persons in recovery from substance use disorder, or PRSUD. This change essentially ensures that reporting better reflects services and outcomes for individuals in recovery. Other than adding this population category, the reporting requirements remain unchanged. States will continue reporting the same measures and following the same reporting process they have in past cycles. It is, though, important to understand the reporting timeline. So in 2026, states reported on the second year outcomes for the goals and objectives established in their fiscal year 24 and 25 plan. In 2027, states will begin reporting on the first year outcomes for the new goals and objectives established in the fiscal year 26-27 plan. So while the reporting framework stays consistent, the focus shifts from completing the previous planning cycle in 2026 to measuring progress on the new fiscal year 26-27 goals. I also want to describe in a bit more detail what states are expected to submit as part of the annual update process. So first, for every indicator included in the report, you must determine whether the outcome for that reporting year was either achieved or not achieved. If an indicator is marked as not achieved, additional information will be required. So in that, you should explain why the target or outcome was not met. You should also describe the actions that you plan to take or the changes you'll make to improve performance and meet the targets in the future. I should also note that the annual update is intended to be more than just reporting results, right? It's an opportunity to assess performance, identify challenges, and document continuous quality improvement. So if a first year target is not achieved, you also have the option to update your second year measurement strategy. So for example, you might find that different data source is needed, or identify new data limitations or caveats that could affect the reported outcome. This is a screenshot of the table that appears in WebBGAS or BGAS, so I won't spend much time on the slide. This should look quite familiar to you if you completed the 2026 report. You can also see here that some of the same fields that I described in my earlier slides.
Let's now turn over to fiscal reporting, specifically SSA expenditures and the maintenance of effort, which are captured on tables 2, 8A, and 8B. 26-27 report cycle, there were a couple of changes made to Table 2. First, we removed recovery support services from row 1 and made these expenditures a standalone row 2. We also added a row 6, for the state's reported expenditures on other capacity building and systems development. There were also some minor reorganization of a couple rows to help improve consistency with other tables. You all visualize these changes and those in other tables. We'll be presenting the tables in a color-coded fashion. Red strike through text are deletions or removals of information. Green are additions, while orange indicates minor adjustments or changes that did not substantively change how the state reports. Tidier version of how Table 2 now appears in reporting on WebBGAS. We'll look at the two maintenance of effort requirements for the SUPTRS block grant, state and women's MOE. For the 26-27 cycle, there weren't any changes made to Table 8A and what the state reports. As for Table 8B, the women's MOE, there were small adjustments in which we added a space for the state to provide or indicate when final and actual expenditures for women's MOE will be made available if the state reports that the expenditures in the table as of December 1st are estimated. This helps ensure that Table B is consistent with the same requirements that we find on Tables 8A and Table 2 when reporting estimated expenditures. Quickly, you'll see these additions and how they'll appear in WebBGAS highlighted in green. To the substance of reporting on these three tables and their relationships. First, all three tables reflect the SSA's expenditures during the most recently completed state fiscal year. For the 2027 report, this will cover state fiscal year 2026 expenditures. And these tables also require that the state submit final and actual expenditures in order to be in compliance. Table 2 captures all of the SSA expenditures broken down by allowable activity and funding source when meeting the state MOE on Table 8A and Women's MOE on Table 8B. State MOE in Table 2 will be primarily focusing on those SSA expenditures reported in Column C for Medicaid, Column E for state funds, and Column F for local funds. The combination of the totals for each of these columns, row 9, should be equal to the state reported expenditures found on Table 8A. If the state doesn't use state match of Medicaid and meeting its state MOE obligations, then we look at just columns E and F for reporting alignment. Here's a quick look at Table 8A and where the state will report the total SSA expenditures made in state fiscal year 2026 to meet its MOE obligation. To demonstrate this relationship around state MOE and examples of good practice, I'm going to walk you through an actual state report from 2026. Here you'll see the state's reported expenditures on Table 2. This is what the state reported in SSA expenditures to meet the MOA obligation on Table 8A. Something to note, the state indicated the amounts are actual and the total expenditures, column A, exceed the average of the state's MOE for the last 2 state fiscal years, seen in column B. Well, let's look at these tables side by side. At first look, columns C, E, and F of Table 2 far exceed what the state reported on Table 8A. Therefore, I'm going to turn to the state's methodology and footnotes on Table 8A to see if I can better understand how much of each of these columns were used in calculating state MOE. Here the state indicates that in Table 8A, the expenditures made comprise of legislatively appropriated funds and state match towards Medicaid. And looking at the state portion of Medicaid listed in Table 8A, which is $125,165,678, I now see that column C of Table 2 reflects all the Medicaid expenditures from the state, and that this $125 million on Table 8A is included in column C of Table 2. So to ensure the state clarifies that the state match for Medicaid is used in meeting MOE and that those dollars are found on Table 2, I checked the footnotes of Table 2 for this clarification. And as you can see here, the state does a pretty good job at showing the reconciliation between Table 2, column C, and Table 8A. They specify that of the total $821 million in Medicaid expended in state fiscal year 2025, $695 million was the Fed portion and $125 million was the state portion. The state even goes an extra step and specifies that the amounts in columns C, E, and F that are inclusive of funds when meeting state MOE on Table 8A. Here the state's math is consistent and clear in demonstrating alignment of how the state is reporting SSA expenditures between these two tables. At state MOE, let's turn to women's MOE in Table 2. We'll focus on this row here, which is row 1A. This row captures SSA expenditures across all funding sources for pregnant women and women with dependent children, or PWWDC. Generally speaking, we look at this row to see if it is equal to or greater than the amounts the state reports on Table 8B, excluding federal Medicaid and other federal funds which may not be used in meeting women's MOE. Here we'll be looking at this third row on Table 8B for women's MOE expenditures. Using the same state example from 2026 report, here's how the SSA reports expending for treatment of PWWDC in state fiscal year 2025 across all their funding sources. Here are how much the state reported expending in meeting the women's MOE on Table 8B. In this, the state reports expending $10,489,317, and these expenditures are final and actual. I also want to point out that these expenditures exceed the state's obligation, which was fixed to those expended in state fiscal year 1994 and are found in the box above the table in Webby Gas. Pulling these tables up side by side, I'm looking for a clear relationship between the amounts reported on both tables. However, we can see that in looking across all expenditures in tables 2, row 1A, the state expenditures for PWWDC exceeds those found on table 8B. So again, we look at the state's reported methodology and footnotes on table 8B first. The state clarifies that the expenditures reported are coded to a specific expenditure authorization index, or EAI. Then they proceed to list those EAI and the amounts associated with them. And here I can see that the math for the methodology works with what's reported in Table 8B, but it doesn't elucidate which funding sources also found on Table 2 that are used in meeting this MOE. Turn to Table 2 again in the state footnotes to see if there's any clarification of this discrepancy. And you can see here the state again provides a great footnote and where it's indicating that of the funds reported in column C, row 1A, 6,036,399 are state match, and that when taking the subportion of column C and state funds in column E, we get that same total reported on table 8B. So I see that this relationship is now clearly made between the tables and no additional information appears needed for this review. We covered a lot with those three tables, but through the examples, we saw some best practices that I wanted to re-emphasize for you all and anticipate you'll adopt in the future. Almost always double check to ensure that the expenditures reported on these three tables reflect those made during the most recently completed state fiscal year, and that those expenditures are final and actual. And to help support this, there should be at least one person who's doing this double checking and looking at the three tables together to ensure that consistency. If there's any discrepancies or the relationship between the state's reporting between tables is not clear, please always use a footnote to explain or clarify that relationship, just as we saw in the example earlier. Best practices specific to Table 2. Always place in the footnote the portion of state Medicaid that is reported in column C in the state if the state uses these state match funds of Medicaid in meeting MOE obligations. Also, the state must also indicate that the expenditures reported on this table are final and actual. If the state hasn't finalized these expenditures and are estimated at the time of reporting on December 1st, the state should indicate when it expects actual amounts to be available, and the table will be updated. Remember, the state is not in compliance with this table's reporting requirements until actual amounts are provided. And to drive this home, the same is true for tables 8A and 8B in reporting actual expenditures for these tables. Remember, these three tables are related. The state must also provide below each MOE table when the actual amounts will be available and the reported expenditures will be updated. Also, the state must provide its methodology for both state and women's MOE in the box that's provided. This means breaking down the reported expenditures by funding source and the exact amounts associated with each funding source. The breakdown in these amounts in the methodology must add up to the total found in the table. In addition, the state must use the same methodology year after year when calculating MOE. Okay, we spent a lot of time on MOE and SSA expenditures. Now let's pivot over to the SUPTRS block grant and the SSA's use of its award. We're going to tackle these in tables 4, 5A through C, 6, and 7 of the section. All 6 of these tables for the SUPTRS block grant award activities cover the award that the state received 3 years prior. So again, for 2027 report, the state will be reporting on how it expended the FY 2024 block grant award, which had a 2-year period to expend, and this period ran from October 1, 2023 through September 30th, 2025. And specifically, Table 4 is what we call the snapshot of compliance. We'll be looking closely at compliance with primary prevention set-asides, early intervention services for HIV among our HIV designated states, and restrictions on the use of funds for administering the block grant. And after we get that high-level look at the state's compliance, we dive deeper into these expenditures on tables 5A, 5B, 6, and 7. These tables help SAMHSA understand how the state prioritized specific activities and expended their awards. All of these tables must align and demonstrate compliance with statute and regulation. Let's look closer at Table 4, our snapshot of compliance. There are some key changes made in how the state is required to report block grant expenditures from the 26-27 cycle onward. We pulled recovery out from row 1, that is otherwise for treatment, and made it a standalone row, which is row 2 for recovery support services. We also added row 6, which captures those block grant expenditures on other capacity building and systems development. And you're going to notice that these changes are consistent with those made on Table 2 of the report. So we found that by adding these rows, SAMHSA has made the one-to-one relationship between tables 4 and the subsequent tables clearer. It also helps us resolve some of the issues in which state reporting across tables 4, 5A, 5B, 6, and 7 experience discrepancies. And we also clarify how reported activities for other capacity building and systems development, those that are reported in row 6 and table 6, are for those activities that support the delivery of direct services, but are not direct services themselves. Here is a color-coded look at those additions made on Table 4. A quick note, here are the 4 areas of compliance, otherwise outlined in statute, that we'll dig into in the coming slides. The first is primary prevention set-aside, in which must be no less than 20% of the state's total expenditures of the block grant award. And for our states that were HIV designated at the time of their award, they're required to expend exactly 5% of those drawn awards on early intervention services for HIV. And then at row 7, we look at those restrictions on the use of block grant funds for administering the block grant, which is capped at 5% of that drawdown of the award. And lastly, row 8 is where the state's reported expenditures must be equal to that state's final drawdown amount, that is at the time of closeout, also known as the state's FFR. Again, this table really is the first check for compliance and how the state expended their award. Tables 5A, 5B, 6, and 7 depend on this table, and we'll discuss those dependencies in greater detail a bit later. And there should be no discrepancies between the total reported on this table and SAMHSA's official record of drawdown, which is the state's final financial report, or FFR. And as with all other tables in this report, there should always be someone who checks and confirms all 5 tables, that's 4 through 7, align. With the updates that were made to Table 4, no discrepancy should really exist between these amounts on the table if completed correctly and following SAMHSA instructions. Here are some quick tips to help achieve these expectations on Table 4. So again, you use the footnotes to write out calculations or break down how the expenditures here in the table align with reporting on the subsequent tables. As many of you in today's webinar will note, we just got through the 2026 report, which was on the FY 2023 award that included TA supplements. Moving forward, do not include the state expenditure of those TA supplemental funds in this or any other tables of the report. Instead, use the footnotes to indicate how much the state received in TA supplement and how much it actually expended of those funds. And this is really because the TA supplemental funds may not be used on direct services, administration, or meeting any of those set-asides that are outlined in the supplemental terms and conditions. Unfortunately, in the 2027 report, this is not really applicable, as there were no TA supplemental awards that were made with the FY 2024 block grant. And like we did before, let's do a rapid review of the state's actual report from 2026 and compliance found on Table 4. To the right are the 3 guiding questions we'll be trying to answer. First of all, does the total, row 8, on this table match the state's approved FFR? And in this case, the answer is no. The state's FFR reflected a final drawdown of $42,361,870, while the total of this table is a few $100,000 less. And so let me double check the footnotes to see if the state clarifies this potential discrepancy. And looking at the footnote, I see that the state indicates it expended $373,656 in TA supplemental funds that were associated with that 2023 award. So I take those expenditures for TA and subtract them from the total found in the state's FFR to see if it gives me the amount reported in the table. And yes, so by subtracting these TA expenditures, I get $41,988,214, which is the same that is found in the total of row 8, rounding notwithstanding. And so after determining the total of the base block grant award expended, I can now look at the primary prevention set aside. For a quick compliance review, we look to see if row 3 for primary prevention, which is direct services, is equal to or greater than 20% of the state's final drawdown of the award. And here we see that in fact the state reports expending more than that 20% of the award, and therefore the initial look of compliance on the set aside is met. Then I'm going to jump down to row 7 and the restriction of use of funds for administration of the block grant. I'm skipping row 4 for early intervention services for HIV because I know that the state was not HIV designated at the time of that 2024 award, and therefore I cannot use funds for these activities. The SSA may not use more than 5% of the final award drawn to support administration of the block grant. So we take 5% of that total base award expended and see that the state actually expended less than that 5%, which was capped at $2,099,108. So here at the first review, the state demonstrates compliant with this restriction on administration. And now that we've done that initial review for compliance on table 4, I'm going to turn you back to Kabai, who's going to walk you through tables 5A through 5B and 6 to show you how these tables interrelate with table 4.
Thank you, Savvy. I am going to continue to build on what has been shared so far by starting with Table 5A, which is designed to capture primary prevention expenditures by strategy and Institute of Medicine categories or IOM categories. This table has remained largely the same when compared to the fiscal year 2024-2025 table. The only notable difference is the addition of columns F and G, which are associated with your COVID and ARP funds. You should have seen these tables when you completed your 2026 report, so know that it will appear the same when it's time to complete the 2027 report. As we continue to look at this table, I do want to share a few reminders. First, please note that funds must be expended in at least one of 6 primary prevention strategies. You might remember that in January of 2022, states were notified through a Dear Colleague letter that states had further discretion to determine the number of strategies selected, and that the selection of all 6 was no longer a requirement. So again, that change in 2022 still stands for this report. The other note that's important to highlight here is that this table in the report has always been a requirement. So all states are expected to document their expenditures relative to the 6 strategies. States that can report on both the strategy type and the IOM category should do so. But if expenditure information is only available by strategy type, then the state should report expenditures in the row titled unspecified for the strategy it falls under. So for example, you might classify expenditures as unspecified under the information dissemination strategy if you're unable to further disaggregate by IOM category. The other element that I want to draw your attention to here is that the total on this table for SUPTRS BG column A must equal the totals documented in tables 4, row 3, 5B, and 7, column G. And we'll talk a little bit more about the kind of interrelated nature of these tables, but know that this is an important element and that's something that project officers are consistently checking for. On the flip side, this table should not include any expenditures associated with other capacity building systems development expenditures. And we'll spend a little bit of time describing exactly what we mean by other capacity building and systems development activities. But again, this is another important element for you to keep in mind. If you used primary prevention set-aside dollars to fund other capacity building and systems development activities, then you should report these expenditures on Table 6, column C. So now that we've reviewed kind of how primary prevention expenditures are organized fiscally, let's take a closer look at the 6 primary prevention strategies and the definitions behind those strategies. I want to note that these definitions are found in the application and the report instructions, so these are accessible to you. And so rather than reading each definition word for word, I'd like to highlight the distinguishing features of each strategy. So starting with information dissemination, which really at its core focuses on increasing knowledge and awareness. These activities are generally one-way communication efforts such as public awareness campaigns or media messaging. Education goes one step further. So instead of simply providing information, educational strategies build knowledge and skills through structured learning. So examples of this could include classroom instructions or workshops and evidence-based curricula. Alternatives provide healthy activities that reduce opportunities for substance use by encouraging positive engagement. These might include youth leadership programs, community recreation events, or substance-free social activities. Problem identification and referral is the next category, and at times I will say this can be misunderstood. These activities identify individuals who may benefit from prevention services or education. And really, most importantly, this strategy is not treatment and is not intended to determine whether someone requires treatment services. So if you have a question about the nuances of this particular strategy, we would encourage you to engage in discussions with your project officer to help kind of tease those out. Community-based process. So this strategy strengthens partnership and community capacity. Activities within this particular strategy often include coalition development, planning meetings, community mobilization, or delivery of technical assistance. And finally, environmental strategies. These are strategies focused on changing community conditions rather than individual behavior. So examples could include policy development, compliance checks, social host ordinances, or other efforts designed to influence community norms associated with alcohol, tobacco, and other drugs, or ATOD. Before I move on from this table, I do want to acknowledge that categories across the 6 strategies are not mutually exclusive. And so activities should be classified according to their primary objectives. They should not be counted across multiple categories. And so if you're struggling to really define something, think about asking yourself, what is the primary purpose of this activity? And is this particular activity part of a larger comprehensive prevention approach? And oftentimes, these questions usually lead to the most appropriate strategy classification. All right, now that we've covered Table 5A in detail, let's move on to Table 5B, which offers another way of viewing the same primary prevention investment. So keep in mind that this is not a separate accounting exercise. Before we get into the contents of this table, I do want to note that this table was added back in during the 2026-2027 reporting cycle. So this may have been the first time some of you completed this table. This is largely an optional table. The instructions note that if the state chooses to report activities utilizing the IOM categories on Table 5A, it must complete Table 5B. So if you chose to complete the IOM subcategories within each of the 6 strategies on Table 5A, and we talked a little bit about this in the last few slides, then you must complete this table. If that information was not available, then you do not. This is an optional table. To summarize the contents of this table, expenditures are grouped according to the populations being served, right, as opposed to the strategies that we saw in Table 5A. And the population categories are what you see in front of you and also in BGAS. Starting with Universal Direct, which are strategies designed to directly serve an identifiable group of participants who have not been identified based on individual risk. For example, after-school programming or parenting classes. The next category is Universal Indirect. So indirect strategies that support population-based programs and environmental strategies could look like establishing policies or modifying advertising practices. The third category here is selective, and these are really activities targeted to individuals or subgroups of a population whose risk of developing a disorder is significantly higher than the average. And lastly, it's the indicated category, and these are largely activities targeted to individuals identified as having minimal but detectable signs of symptoms foreshadowing disorders or having biological markers indicating predisposition for disorders but not yet meeting diagnostic levels. By and large, the important point here is that these expenditures should align with what was reported in Table 5A. So really as a quality assurance step, you want to compare whether the totals on this table match the total expenditures reported in Table 5A. And if those totals don't match for one reason or another, it's usually an indication that expenditures were omitted or classified differently between the two tables. All right, moving on to Table 5C, which shifts from primary prevention expenditures to primary prevention priorities. The updates made to this table are highlighted in green, and as we saw in prior prevention tables, COVID and ARP columns have been added. Under the priority substances section, the tobacco category has been updated to include nicotine-containing products, and you'll also see an other category which has been added. Under the priority population section, the college-age individuals category now includes an age grouping. And the last item that's new here is the older adults ages 55 and above category. In terms of the overall contents of this table, here states are identifying the priority substances and populations addressed through their prevention efforts. So really this table helps us understand your prevention priorities. And I'll just add that there are no required numbers here, only accurate identification of the priorities addressed during the reporting period. And so when you're completing this table, really think about where your prevention investments were intentionally directed. All right, so we have now discussed direct prevention expenditures. Next, we'll look at activities that support prevention, treatment, and recovery support services, but are not themselves direct services. To start with, Table 6 underwent some structural updates. The title now better reflects its purpose by emphasizing the other capacity building and systems development activities, and you might have noticed this by now. The integrated column has been removed, and a new recovery support services column has been added. And lastly, the two sub-rows below each activity area has been added. So in your expenditure report here, you should break down the amount expended for each activity by how much was expended by the SSA and the amount that went to your subrecipients for each category. So this could include expenditures involving the time of state personnel or subrecipient resources. It is important, however, to note that these expenditures do not include the SSA's expenditure for administering the block grant, otherwise reported on Table 4, Row 7. So this is a visual of all of the changes I just described. Again, I won't spend much time on this. You can see the new items in green and the items in red, which have been removed. And here's a clean version of the table, which is very similar to the version that you'll see in WebBGAS. Before we move on further and get into the definitions behind the 7 categories on this table, I do want to highlight a few points. The first point has been covered earlier in the presentation, but again, to emphasize, this table should only reflect expenditures that went towards activities that are in support of the direct services described on Tables 4, 5A, 5B, and 7. Again, this does not include SSA expenditures reported on Table 4, Row 7 for administering the block grant. Again, only those other capacity building systems development expenditures for treatment, recovery support services, and primary prevention should be reported on this table. The last thing I want to cover on this slide is that the combined expenditures reported across columns A, B, and C should reconcile with expenditures reported on Table 4, Row 6. And so if those totals don't match, you'll want to begin looking for omitted expenditures or reporting inconsistencies. Another best practice is documenting your reconciliation calculations in the table footnotes. And so those explanations often answer project officer questions before they're even asked. I won't spend too much time on this slide because we covered most of these items, but these are a few helpful tips. Footnotes are your best friend, especially on this table. Much like Table 2, put in footnotes that match and connect between this table and Table 4, Row 6. There should be no discrepancies, right, between what's reported on this table and the amounts on Table 4, Row 6. And lastly, consider footnoting how the sum of Table 4, Row 3, and Table 6, Column C meet the primary prevention set-aside requirements. And we'll spend a little bit more time on that last point. All right, now let's pivot slightly into the meat of what makes up the categories associated with Table 6. So think of Table 6 as documenting the infrastructure that allows for direct services to occur. And although these expenditures may never directly serve a client, they improve the quality, accessibility, and sustainability of prevention, treatment, and recovery services. And so the slide in front of you provides definitions for each capacity building category. And again, these definitions are found in the instructions online. And so rather than reading this slide line by line, I'll cover in broad strokes how you might be able to think about the overall purpose and intent of each activity. And so when we think about information systems, it's helpful to ask whether the particular activity is improving your treatment data system or your prevention data system, right? Are you making an investment to enhance your information systems? The same logic follows through with infrastructure support. Is this activity providing some sort of infrastructure support to help services that you provide? So for example, investments in hotlines, mobile crisis teams. The next category is related to partnerships, community outreach, and needs assessment. And we know that all of you have conducted some sort of a needs assessment to help inform your program and service delivery. So this is an example of an activity that would fall squarely under this category. Planning Council related activities support the work of your Behavioral Health Planning Council, or if your state has one, a SUPTRS Block Grant Advisory Council. Moving on to quality assurance and improvement, these are activities that should be designed to improve the overall quality of your services or programs. So think about those initiatives that help meet professional standards or review implementation of evidence-based programs. The research and evaluation category, I think, is pretty self-explanatory, right? Are you investing in wholesale evaluations of your services and programs? And last but not least, training and education. Are you providing skill development for your workforce? Really, this is an example of costs or expenditures that would fall, again, squarely in this particular category. As we've noted earlier on the call and relative to the 6 primary prevention strategies, categories here are also not mutually exclusive. So selecting a category that best reflects the primary purpose will generally lead to accurate reporting. Before we move on from Table 6, I want to leave you with a tip for accurate reporting, particularly for primary prevention. You want to carefully review definitions to help distinguish the 6 primary prevention strategies from the other capacity building and systems development activities. So, for example, we know that many of you are investing in community or youth coalition building activities to help advance prevention outcomes across your state. This is an example of an activity that's more appropriately captured under the community-based process category, which is one of the 6 primary prevention strategies. This is a common source of reporting error, but one that could easily be resolved by paying close attention to the definitions that are provided.
Last but not least, our fiscal review of the annual report. Let's talk about Table 7, the state entity inventory. Okay, so during the 26-27 cycle and moving forward, minor changes were made to this table. Most of the changes were structural, and so we've rearranged the order of columns to help ease that review process. So now you're going to see that state expenditures for PWWDC, OTPs, and OBOTs, which are direct treatment services, immediately follow the larger column for treatment expenditures, which is column B. And As we mentioned earlier, to help improve the alignment between this table and table 4, row 2, we've added the standalone column, column E, for entities that receive block grant funds for recovery support services. We also note that we removed the column for certain service programs, as that past approval and reporting of these activities and expenditures are otherwise captured on table 3A and 3B. Here is that color-coded visual of these changes. State entity inventory, states must enter all subrecipients who are funded with block grant award in which they are reporting. For treatment providers, they are required to be registered with SAMHSA and have an IETF ID, which is our inventory of treatment facilities. For those providers that provide solely primary prevention, they will not have an IETF ID, and therefore the second column from the left must be marked with an X. If the state uses pass-throughs, so those are your county administrators, the state must still report all providers that those pass-through entities funded on this table. Every block grant dollar that was spent on direct services for prevention, treatment, and recovery support services need to be accounted for on this table. This table does not include any of those block grant administration expenditures that you report on table 4, row 7, and it does not include any other capacity building or systems development expenditures. Those are reported only on table 4, row 6, and table 6. A general rule of thumb for the column sums is that they should be equal to what's found on table 4. So for treatment services, column B's total should equal table 4, row 1. Recovery support services, that total in column F should be equal to table 4, row 2. Primary prevention, total column G, should equal table 4, row 3. And then for our designated states, early intervention services for HIV and column H should match table 4, row 4. Let's look at each of the columns more specifically. So column A is a sum across all of your providers. And the sum of table 4, so row 1 plus row 2 plus row 3 plus row 4, should equal to the totals of column B plus F plus G plus H. And this column is actually auto-calculated by WebBGAS using the amounts entered by the state for each provider. And moving over to column B, this captures all those direct treatment and prevention services, not including primary prevention. And so when we look at column B, this should be equal to the total in table 4, row 1. And for treatment, column B is inclusive of column C, D, and E in this table. So in other words, these columns, C, D, and E, are subcolumns of column B. And therefore, the amounts reported for each entity must be less than or equal to the amount for that same entity in column B. To drill into this a little bit more, so column C should reflect the portion of column B that went into providing direct services for pregnant women and women with dependent children. And so in the case where a provider only serves pregnant women and women with dependent children in specialty services, column C should be equal to column B for that provider. If the provider treats or serves any other populations outside of PWWDC, then column C is going to be less than column B. When we look at column D, if the provider is an OTP and doesn't specialize in women's services, then that column D is going to be equal to column B. And then when we look at column E, if the provider is an OPA and does not specialize in women's services, that column E will be equal to column B for that entity. And moving along, column F is where we're capturing all those recovery support services in the state. And so when we look across all entities that receive block grant funds for delivering recovery support services in column F, that total of all entities should be equal to table 4, row 2. Our column G is where we look at those primary prevention providers in the state. And so when we look across all primary prevention providers in column G, that total should be equal to table 4, row 3, and table 5A, 5B. And last but not least is column H for our designated states for early intervention services of HIV. So if the state was designated in fiscal year 2024, the state is obligated to expend exactly 5% for these services, and the sum across all the entities that receive these block grant funds in Table 7 should be equal to Table 4, Row 4. Now let's pull up Table 4 next to Table 7 to do a side-by-side comparison to ensure that the totals across the columns on Table 7 match what we're seeing on Table 4. To start looking at Table 4 first, we look at Row 1, which are those direct services for SUD treatment and prevention other than primary prevention. And we see that on Table 4, the state reports spending $22,034,198. And when we look across all entities on Table 7, the grand total of those entities is equal to the same, which is $22,034,198. So there's a match. Moving down to recovery support services on Table 4, the state reports expending $2,107,634 for those services. And when we move over to column F on Table 7, across all those entities reported as having received block grant funds for recovery support services, that grand total also equals $2,107,634, which is again a match. For Row 3 of this table's report, they report expending $10,941,611 in direct primary prevention services. And on Table 7, column G, across all those primary prevention providers, we see that their grand total of expenditures is also equal to that $10,941,611. Again, this is a match. But not least, while the state was not HIV designated, we should just do a quick look to ensure that while the state reports not spending any funds on Table 4 for these early intervention services for HIV, that they are consistent with that reporting on Table 7. And as you can see here, $0 on Table 4, Row 4, and $0 under column H on Table 7. Now we've wrapped up Table 7. I'm going to turn it back over to Kabai to dive deeper into primary prevention.
All right, thank you, Savvy. I will now provide a deep dive into some of what we talked about when we covered the primary prevention tables at the top of our call, and describe the interrelated nature of these tables with some examples for reference purposes. So let's begin with Table 4 because everything else builds from that table. So by now we know Table 4 answers a very straightforward question. How is the SUPTRS Block Grant Award spent? In this example, we have a $1 million block grant award. Nice, clean number. Of that award, we could see in Row 3, $150,000 went to support direct primary prevention services, so one of 6 strategies. And another $50,000 went to support primary prevention-related capacity building activities, as you can see in Row 6. These two numbers become important as project officers review your report. As we've mentioned, the statute requires that states spend at least 20% of their block grant award on primary prevention. One mistake we occasionally see is assuming that only the amount reported in Table 4, Row 3 count towards that requirement. That's not always true, right? If other capacity building and systems development activities directly supported primary prevention, then those dollars may absolutely count towards the primary prevention set aside. And that's exactly what's happening in this example. You have $150,000, again, reported as direct primary prevention services, plus the $50,000 in prevention-related capacity building activities, which together equals $200,000. When we divide that by the $1 million block grant award, here, the state clearly meets the 20% prevention requirement. Now let's focus specifically on the direct primary prevention dollars reported in Table 4. The amount reported in row 3, again, doesn't stand alone. So let's look at Table 5A. Imagine your state spent $150,000 on direct primary prevention activities. So Table 5A asks, how was the money used? Every primary prevention dollar should be assigned to one or more of these prevention strategies, of course with the exception of other capacity building activities. Table 5B reorganizes exactly the same prevention expenditures. Instead of asking which prevention strategy was used, it asks who was the intended audience. The table provides another lens for understanding prevention programming. Again, the total prevention expenditures should remain the exact same, only the organization of the information changes. Finally, Table 7 answers one last question. Who actually received these prevention dollars? Each provider receiving prevention funding should appear here, again, with the exception of those that received other capacity building services. When we total the primary prevention expenditures across all providers, that total should equal the expenditures reported in Table 4, Row 3, Tables 5A and 5B. Notice how each table is reinforcing the other. We'll finish this section by returning to Table 6. Earlier we discussed the $50,000 in primary prevention related capacity building. That money doesn't disappear, right? Instead, it's reported in Table 6. Your project officer should be able to start with Table 4 and follow those dollars through Tables 5A, 5B, 6, and 7 without encountering inconsistencies or unexplained differences. That traceability is one of the strongest indicators of a high-quality SUPTRS block grant report and significantly reduces the need for revision requests and follow-up questions during the review process.
Moving through to Section D of the annual report, let's talk about population and service reports. Below are the tables that make up this section of the report. For today, we're going to only focus on the population and service tables for SUD treatment and recovery support services, which will be found on tables 10A, 10B, and 11A. So table 10A is referred to as the treatment utilization matrix. There weren't any changes that were made to this table for the 26-27 cycle. But we did want to make sure that we emphasized that beginning back in 2022, states were instructed that this table should no longer reflect all publicly funded treatment admissions and persons served. Rather, in this change, it allows SAMHSA to better understand and monitor performance and how states use block grant funds for funding substance use treatment. So the state should report only those admissions and persons served using block grant funds during this most recently completed state fiscal year. And we're also going to note that in the title of the table, we refer to unduplicated counts. So here the columns where the state reports persons served is where those unduplicated counts are being reviewed. Because a person can be readmitted to a single level of care or across multiple levels of care in the same state fiscal year, when we look at those admissions compared to persons served, it's expected that at any level of care, the number of admissions during that period is equal to or greater than the number of persons served. I was going to make a quick note that table 10A and 11A are related, but we're going to hop on that a little bit later. Here's a screenshot of how table 10A appears in WebBGAS. The table's large, so only in the first few levels of care are shown here. And so in this example, you're going to see that column A, the state reports 15,189 admissions to that freestanding with residential withdrawal management during state fiscal year 2025. And then that of those 15,000 or more admissions, there were 10,524 unduplicated counts of persons served using those block grant funds. And so in this case, this is telling me that there's a portion of those persons served who were admitted multiple times to freestanding residential withdrawal management in the report period. All right, moving forward in the report, we have table 10B. That's going to capture those number of individuals served with recovery support services stratified by sex and age. So beginning back in 2024, states were required to begin reporting the number of persons served with recovery support services under the block grant during the most recently completed state fiscal year. And so here, states are required to report only those served with recovery support services that were paid in part or whole by the block grant. Here's another screenshot of a portion of Table 10B and how it appears in BGAS. Again, this table is large due to that level of stratifying persons by sex and age. So here you're just going to see a portion of the table. And you can see that the state reports that it served 292 women across all those areas of recovery support services in state fiscal year 2025 using block grant. And they've also served 806 men with block grant funds during that same period. The last table of this section that we'll be discussing is Table 11A. In the 26-27 report, moving forward, we've removed Table 11C, which had states stratifying admissions to SUD treatment by sexual orientation. So this table looks at the unduplicated count of admissions to SUD treatment, regardless of which level of care they were admitted to on Table 10A. And it stratifies these admissions by race, ethnicity, sex, and age. And so similar to Table 10A, beginning in 2022, the states were instructed that they should no longer report all publicly funded admissions to treatment, but rather they should be reporting only admissions that were funded by the block grant during that most recently completed state fiscal year. So again, this is to help us at SAMHSA better understand and monitor performance of the states when using block grant funds for SUD treatment. And I mentioned on Table 10A, there is a relationship between the treatment utilization matrix and Table 11A. So states should understand that Table 11A is a subset of Table 10A, and that Table 11A presents the unduplicated admissions across all levels of care found on Table 10A. So when we compare the total of persons served on Table 10A to the unduplicated admissions on Table 11A, there should be less than or equal to those total persons served. This is because we understand that on Table 10A, a person can be served across multiple levels of care. And so in Table 10A, it's a true unduplicated count of those persons, regardless of how many levels of care they came in contact with and were paid for by the block grant. This is another screenshot of a portion of Table 11A and how it's going to appear in WebBGAS. All right, to round out this table section, I'm going to point out some additional key elements for Report Table 11A. And so first, we recognize that Table 11A is going to capture only those admissions that were made within a state fiscal year. But a lot of times you all are serving individuals with SUD treatment on a continuous basis, and those admissions are going to have occurred prior to the start of the fiscal year of the report. So using the box below the table, the states can report how many persons were admitted to SUD treatment prior to that 12-month period that were funded with block grant dollars. Additionally, Table 11A is only going to be looking at those admissions at those 10 levels of care found on Table 10A. But states are going to be using block grant dollars to fund additional levels of care that aren't reflected on Table 10A. So go ahead, use that box and provided to you all to report those admissions at other levels of care that were funded during that period by block grant. Lastly, states should indicate whether the values that are reported within the table are generated using a client-based system where each client is given a unique identifier. And always, it is in the interest of the state to always utilize the comment boxes within the table and others, as well as footnotes, to just document how the state arrived at the values that are placed in the table, especially when there are caveats and limitations. We are in the home stretch and last section of the report, performance data and outcomes. This section of the report is going to capture the national outcome measures, or NOMs, and some additional primary prevention performance. For SUD treatment, we're going to look at tables 14 through 20, which capture treatment NOMs. Tables 21 to 29 are your primary prevention NOMs, or PNOMs, and then tables 30 to 34 are those additional primary prevention performance measures. Many of these tables are going to be completed for you all on behalf of the state using SAMHSA and other federal data sets. But I wanted to take a quick moment to emphasize the expectations when it comes to reporting treatment NOMs that are found on tables 14 through 20. So nothing on tables 14 through 20 has changed for the 26-27 cycle. but we wanted to remind states that the SSA is required to collect data on all areas of the NOMS at both admission and discharge. And this is going to be regardless of funding source that's overseen by the SSA. This is going to be how SAMHSA understands the SSA's overall treatment system and performance in these established areas. States who have state agreements under the Behavioral Health Services System, or BSIS, are required to report data into TEDS, and TEDS is going to capture that client level admission and discharges as well as this NOMS data. So those BSIS agreements include all 50 states, DC, and Puerto Rico. And these agreements and the requirements to report data into TEDS that is complete and of high quality is important to emphasize. And this is because that TEDS data is used to populate tables 14 through 20 in the state's annual report of the block grant. So if the state's underperforming when reporting client level data into TEDS, this is going to directly impact the state's reporting and SAMHSA's review of performance with the block grant annual report. As for our territories, tribe, and others not funded through BSIS, the data for NOMS still needs to be collected and reported manually into tables 14 through 20. And for everyone, to better understand how NOMS are measured and captured, please refer over to the TED State Manual for more details. Alrighty, I'm going to turn it back to Kabai, who's going to wrap us up for this portion of today's webinar.
Thanks, Abby. We'll now transition from treatment outcomes to primary prevention performance measures, which summarize the reach of primary prevention programming, the types of interventions implemented, and the extent to which evidence-based practices are being used. One area that occasionally causes confusion involves reporting periods. Notice that these tables require you to specify both the beginning and ending dates for the reporting period. When completing this table, be sure that those dates correspond to the period used to generate the reported data. Consistency between the dates and the reported information is an important quality assurance step. The correct reporting period for the first three tables, tables 31, 32, and 33, is calendar year. If your state is unable to report on calendar year 2024, please indicate in this footnote why you're unable to report on the calendar year and the steps you intend to take to make calendar year reporting possible in the future. The correct reporting period for report table 34 is the 24-month expenditure period of the federal fiscal year 2024 SUPTRS BG award. I do want to note here that nothing has changed on this particular table. I want to touch briefly on Table 31 to highlight the change made during the 2026-2027 report. This is the only primary prevention performance measures table that has been updated. Now, you might remember that we asked you to report on the number of people served and the number of people reached under two separate tables. We have since 2025 consolidated those two measures into one table. Information is reported across several demographic categories, including age, sex, race, and ethnicity. So when reviewing your data, confirm the demographic totals remain internally consistent across categories within each table. Before I cover this slide and to help kind of close this out here, I want to recognize that there is strong interest in and a clear need for more time to unpack the primary prevention performance measures. But given the time constraints of this training, we are now exploring the feasibility of offering a separate session dedicated to these measures so they can receive the attention they deserve. But please know that your feedback has been heard and it is informing our planning. But for the purpose of this training, it is sufficient to note that no other changes have been made to the remaining primary prevention performance tables as you see in front of you. Thank you.
Thank you, Savvy. Thank you, Kabai. At this time, we will begin the question and answer segment of the presentation. If you've not already done so, please submit your questions by using the Q&A feature that's located on the bottom of your screen. Our first question. For a managed care state still working to implement how to capture RSS and other capacity building expenditures separate from other buckets, does SAMHSA prefer we report 0/not tracked or use managed care partner self-reported data?
I'll go ahead and answer this as it relates a bit more specifically to the CSAT side of house. So if a state uses a managed care organization, the state is still required to enforce all block grant reporting requirements on that managed care organization. So that means anything that relates to expenditures or client level data or even capacity building expenditures are the responsibility of the SSA for monitoring and enforcement on that managed care organization. Once it moves over to the managed care organization, the SSA does not relinquish its responsibilities for ensuring that that managed care organization meets those requirements. And so we're expecting that regardless of using a managed care organization or not, all of these reporting requirements are being met annually.
Our next question. How does SAMHSA want states to capture subrecipient administrative costs for primary prevention? Currently, we report them in 5A because they are not discernible from direct service costs in our reporting.
And this is, I can jump in on that. And that's an appropriate way to classify the expenditures, particularly because I'm assuming here that that provider is not providing any other capacity building services. And so that's an appropriate way to classify expenditures in one of the 6 primary prevention strategies.
Our next question. Have states been able to pivot well to the change in 10A reporting from all public funds to sub-G services only? Is SAMHSA concerned at all about the natural drop in numbers that may occur?
Great question. So as you might have encountered over the reporting cycle, your project officers should have been working closely with you to help you better address this reporting requirement shift that went in effect 2022, which is also part of why we wanted to reemphasize this requirement here in this webinar. So I would recommend that if you currently are not able to or are looking for paths forward, to reach out to the state TA that's provided by SAMHSA, and we can help link to some best practices or even some peers that are doing a good job. One thing to note, some states use, for example, their billing level data to help support capturing that block grant funded subrecipients with their providers. And as it relates to that natural drop in the numbers. So this change was actually in response to the Government Accountability Office that indicated that SAMHSA needs to better capture performance of the block grant and that this table was not performing that way. So this is why the change occurred. That being said, the states that report into TEDS should be capturing all client level data in TEDS that are administered or overseen by the SSA. So while table 10A will see some drop-offs, we expect that your TEDS performance should remain about at the same level as it has been.
Our next question. How does a braided funding approach relate to the use of SUPTRS BG funds in the reporting of data?
I think this braided funding applies more to our treatment side, so I'll answer this as well. So when we look at the client level data, which I believe is kind of when this question popped up, is that as long as an admission or a person served was funded in part or in whole by the block grant, that those individuals would be reported into those tables for performance. So regardless of the amount, that admission would be counted as long as the block grant dollar touched it.
Our next question. Is SAMHSA going to update the treatment service setting to reflect current ASAM levels of care?
Great question. This actually came up at NASDAD as well. So this is something both the annual reporting requirements as well as TEDS and other elements of data that are collected by SAMHSA get updated on a fixed cycle. And so any adoptions of these new ASAM level criteria will be incremental and to ensure that we have some continuity and a fully assessed that transition for data quality and assurance over time. And so if there will be, or when there is a shift over to those ASAM levels of care, SAMHSA will notify and work with you all through all of our data mechanisms that are available.
Our next question. Are there activities that programs commonly misclassify that attendees should be aware of?
I can jump in really quickly. One of the things I mentioned during the training are just activities that might be associated with one of the 6 strategies. So under the community process category, oftentimes, activities within that bucket may be misclassified to sort of fall under other capacity building or systems development activities. So again, just want to circle back and encourage folks to really pay attention to the definitions found in those 2 buckets to determine, where your activity is most appropriately captured. So that's one thing that we see on the prevention side that want to flag for folks.
Yeah, on our side, I think the biggest transition, and this is part of why we pulled out recovery support services, for example, out from underneath treatment, because that generated, once that requirement was passed by Congress in statute, there was a little bit of confusion of how that actually gets fully captured, especially when a provider does a little bit of both, and treatment is not quite the same as recovery support services. So to try to respond and address that and fully capture recovery support services, this is why we've made that intentional kind of pulling out of recovery support services across all of our tables to ensure that those classifications are consistent and reflective throughout the report.
Our next question. Are there services that cannot be counted as recovery services, even if they may support recovery?
Good question. So under the SUPTRS block grant, as well as the mental health block grant, SAMHSA has specific and kind of well-defined allowable recovery support services that may be used, in which block grant dollars may be used. And so in that instance, I refer the states over to those allowable activities. In instances where perhaps an activity is not covered by that exhaustive list that was developed by SAMHSA, you should reach out to your state project officer and consult with them in advance, as your state project officer would have to approve any other activities beyond that list provided.
Our next question. Is there a public-facing site where the reporting instructions can be found?
Good question. So in terms of the really detailed instructions that really pertain to WebBGAS themselves, those are accessible only from a user login in WebBGAS. And so I defer over to your coordinators or your other state staff point of contacts to go into WebBGAS, and you can download and print those PDF versions of WebBGAS instructions. Otherwise, the QR code that we presented at the beginning and that's linked up in the chat earlier gives you that entire set of block grant reporting requirement tables. You could also just do a quick search in Google or on the SAMHSA web page for SUPTRS report tables.
Our next question. What types of priority indicators will SAMHSA be looking for in future SUPTRS block grant applications and reports?
So at this time, we try to, as I mentioned earlier about data reporting, is try to stay as consistent as possible year to year so that we can do this comparison and really clear trends in the state's use of funds over time. That being said, anytime there are changes or proposed changes to the block grant reporting requirements and plan, these go up for public commenting, which will be available on the federal register site. So this usually happens in the fall every couple of years. And so once that goes out, I'm sure your project officers will let you know that those are available for review and comment. Hope that answers it.
All right, our next question. Our SPO has stated that the guidance documents on RSS allowable activities for SUPTRS BG and mental health BG are not current and do not use them. This is also reflected on the SAMHSA website as the doc has been removed. Do you know of any target date for the release of that?
Great question. So for right now, for the purposes of this reporting webinar, all of those categories were approved categories that are going to the 2027 report. Once it comes to kind of moving forward and looking ahead with those approved SAMHSA requirements, SAMHSA will release and publish that, but in terms of date, I currently don't have an answer to that.
And our next question. how can we be efficient in data collection and reporting to comply with requirements?
I've answered a lot. You want to take some?
Sure. I would leave you all with, I think we provided quite a lot of information in terms of, things that you should be paying attention to, especially as it relates to the interrelated tables. The tip again I would leave you with is just to make sure that there's somebody doing the quality check once the tables have been completed, recognizing again, the tables are interrelated, but the data source may vary across tables. And in addition to that, the folks submitting the data or entering the data might vary across various tables, right? And so we see some discrepancy just because that QC process may have not sort of taken place. And so would leave you with just a tip to, once all of your data is entered and your expenditures have been populated, really sort of elevate and emphasize the QC process just so that you're able to reconcile across your expenditures and your performance data. Anything else you want to add to that?
Yeah, and what I'd also note too is, like I mentioned before, generally the bulk and the primary reporting requirements of the block grant have remained pretty consistent over time with some minor changes here and there. And so once you all are coming to the end of your state fiscal year, or even throughout the year, just start preparing and regularly checking back in those reporting requirements, WebBeGAS or through the SAMHSA PDF version of those reporting requirements, to ensure that you're starting to prep and clean that data, whether it's expenditure or client level data, to get it ready and geared up, and then do those quality checks like Kabai shared, and prepare early and often.
Okay, this concludes our Q&A portion of today's webinar. As a reminder, the recorded webinar and PowerPoint slides will be made available and shared with participants. Next slide, please. Free technical assistance is available to grantees. Through the SAMHSA State TA project, technical assistance is available at no cost. To access TA resources or to simply learn more, you can do so by emailing samhsastata@jbsinternational.com. Next slide, please. All attendees will receive a link to complete a survey at the conclusion of today's webinar. The survey will be sent via Zoom directly following today's presentation, and again 24 hours later. We ask each of you to take a few moments to complete the evaluation, as your feedback helps shape future webinars. The survey can also be accessed by using your smartphone's camera to scan the QR code shown here. Again, we ask that each of you take a few moments to complete the evaluation, as your feedback helps shape future webinars. Next slide, please. And lastly, we want to extend another thank you to Spencer, Torrance, Savvy, and Kabai for leading today's presentation. We also want to thank each of you for being in attendance this afternoon. We hope each of you have a great rest of your day, and we hope to see you again at a webinar in the near future. Thank you.